We're delighted to have Dr. Niamh Appleby with us today. Dr. Appleby is from the Oxford University Molecular Diagnostics Centre and an expert on researching personalised treatments for blood cancer patients. She holds an award from Health Education England Genomic Medicine Fellowship to continue her work exploring the early stages of CLL.
Thanks for the introduction. As Brian said, I'm working in Oxford and with a particular research interest in early chronic lymphocytic leukemia and figuring out how it goes, where it comes from in the first place, but also how it goes from early stage disease and why it stays at early stage disease for some people and why it moves and gradually gets worse over time and comes to the point of needing treatment for others. So I have a few slides to talk through, which are done my best to keep them non-technical, and then I'd like to talk about a study that is open in Oxford at the moment, and we're recruiting particularly for early stage disease. The theme of my talk is looking around early stage chronic lymphocytic leukemia, and I've broadly divided. If we can flick through to the next slide. I've broadly divided the talk into three sections. I wanted to talk about how early chronic lymphocytic leukemia is thought of at the moment, and I guess that has probably reframed for a lot of people in the last 12 months. I'm also I'm then going to talk about where watch and wait, and this idea that we pause and or active surveillance, that we pause and monitor people for a period of time, where that comes from. And what are the assumptions about the disease that underlie that? And finally, I'm going to talk about the OxPLoreD study, which I hope will bring some changes to the chronic lymphocytic leukemia community in future. So if I can get my next slide, please. So we think about, I suppose, the sort of medical model of early stage CLL is we pick most people up at this early CLL or orange arrow stage. And lots of people, like Stephen mentioned earlier, will have this come completely out of the blue when they've had a blood test done for another reason. Either they're having a minor surgical procedure, they're having a cholesterol check, and somebody notices that the white cells don't look quite right, and that triggers a series of investigations. So the medical model of this is that what we're most interested in, and what a lot of the previous studies have looked at, is that it's very simply this time point going from early CLL until you hit the CLL requiring treatment. I think if we can go on to the next slide now. But of course, COVID has thrown this in huge stage, really brought this to the fore, that early CLL is more than living your life without needing a CLL specific treatment. We've known for many years that people with early stage CLL are more vulnerable to flu and pneumococcal disease and more vulnerable to winding up in hospital after those infections. And we recommend our own patients get an annual flu vaccine and the pneumococcal vaccine every 5 years. We also know that people living with early CLL are more vulnerable to skin damage from ultraviolet light in the sun. I'm recommending the patients I see in Oxford to get at least a sun protection factor 30 and wear that while outdoors, even in the winter time. We'll talk a little bit more, I think, about COVID specifically in the Q&A section. So I move forward here. So I was very heartened to see in the quiz or in the questionnaire at the start of the stuff that we have some improvement since the Watch, Wait and Worry survey almost 3 years ago now. This was a survey specifically targeting people living with early CLL, looking at what their experience of living with the disease was, and in that study, over 2/3 of them, hadn't met their clinical nurse specialist, didn't know how to get in touch with them. And I'm pleased to see that at least the cohort coming to this webinar were able to benefit from linking with their CLL support organizations. And again, I was not at all surprised to find very few people felt they got too much information, and most people felt that they got not enough or just right. If I can move forward again. So talk a little bit about, this active surveillance, which is a term I prefer to the sort of more historical watch and wait. Um, and why do we do this? Because this is an unusual thing to do with when we think about cancer in general, this is the message that we give our people with chronic lymphocytic leukemia is quite different to the message people with, say, early stage breast cancer or early stage bowel cancer get. And the reason we do that is in part is because maybe if I slip forward in the slide, we don't. So we don't. So this is a sort of very broad model of what happens in chronic lymphocytic leukemia as it develops. The disease comes from a B cell or a B lymphocyte, which is a white blood cell, which has a normal role in your immune system and in fighting response to infection, particularly bacterial infection. Somewhere, over the course, one of these B cells develops an abnormality in the genes, either in a chromosome or in a gene, which causes it to behave differently from a normal B cell. It lasts a bit longer. It doesn't work as well in terms of an immune function. And over time, the numbers of these abnormal B cells increase and acquire additional mutations. So we pick up people, as we said, probably at the early CLL stage, and we see some people for the first time when their disease requires treatment. So the idea, what we're doing by waiting, when monitoring people with early CLL, means that when they come to treatment, they have more abnormal cells on board, and it's a slightly more difficult job to get rid of the abnormal cells when there's more of them there. If we flick forward here again, the challenge with CLL and why it's, I suppose, a bit different to things like breast cancer or bowel cancers is that CLL patients are, there's a big difference from one CLL patient to another, and within the group of CLL patients, we have a small number of people in whom the disease is going to progress or get worse over a relatively short period of years. We have a number of people, roughly a third of people diagnosed with early stage CLL are never going to need any treatment. And then we have another group in the middle that will need treatment, but after many years. And what we don't have at the moment is a good way to sort those patients out into different groups using blood tests or other tests or other investigations, and to be very confident with how well our sort works. Can I move forward again? So the idea of treating early stage CLL has been tried, in giving treatments to people with early stage CLL has been done before. And there's been trials of everything from fludarabine to XCR, and there's an ongoing trial in Germany on ibrutinib for early stage CLL. The problem with the previous trials is that none of them have shown a benefit to people with early CLL from getting early chemotherapy. And that, chemotherapy is toxic. And what you end up doing is giving people unwanted and adverse effects, and you end up treating people that, if you left them alone, would have been very well for many years without treatment. If we move forward here. So in summary, active surveillance for watch and wait exists because previous studies of treating early CLL did not show a benefit. My hypothesis or my thought is that the reason this didn't show a benefit is it was, firstly, we were unable to pick out who was really going to progress and who was really going to benefit from early treatment. And on the converse side, the treatments were too toxic. So the CLL community has made a huge I mean, CLL treatment has changed hugely over the last sort of 10, 15 years. We've got a lot of new targeted therapies. But over that same time course, how we deal with early CLL hasn't really changed. We're still stuck in this, active surveillance model where we're very much focusing on the time from diagnosis until the treatment. What we're not focusing on, and I think, as a medical community, we need to focus on going forward, is the impact on living with early CLL on both on the person itself and also on how they other illnesses like infection and other health related parameters like how much time they spend in hospital. Does it impact on things like their bone health? So I think we need to look more broadly and take in data sets from not just looking at the blood results. I think perhaps we've been a little bit guilty of just looking at the blood results. Could I get the next slide, please? Oh, okay, keep going. I look like there's an animation there that shouldn't be there. So now these are so currently in Oxford we're running the OxPLoreD study. This is a study that's recruiting people with monoclonal B lymphocytosis and early CLL. We're interested in people that have been diagnosed in the last 3 years. The study is aiming to develop tools that will help distinguish with who is going to progress and who is going to have long-term stable disease. We're doing this with using 3 study assessments over 5 years, collecting blood samples, but also collecting data on the person's quality of life parameters, how they experience the disease, and what their any other health-related outcomes, including hospitalizations or treatments for significant infection. At the end of it, if we follow this group of patients for 5 years, a minority will have progressed to CLL requiring treatment, and the majority will probably be staying with early CLL. So we need big numbers. We're hoping to get something like 1,600 patients through this study to follow over 5 years to generate the kind of data we want. And my last slide here is I just don't pay too much attention to the text. What I'm trying to show you is a schematic of the kind of data that will be coming out of the OxPLoreD studies. So not just the blood tests, the quality of life parameters, also data like how often are you coming to a hospital, how many blood tests have you had over a period, so that study is currently up and running in Oxford. Yeah, this was what I was going to try to I suppose just show you with the color schematic different types of data that we need to make a really robust tool to divide this up. Probably maybe we should go to the animation now.
Oxford University doctors and scientists need you. Join us and be part of a groundbreaking study aiming to detect blood cancers at the earliest possible stage. Some people can experience changes in their blood which might mean they develop a blood or bone marrow cancer in the future. But this doesn't necessarily mean they will need immediate treatment. And only a small minority of people who experience a change in their blood will go on to develop blood cancer and require treatment. Currently, doctors use watch and wait to monitor these people. They visit their doctor a few times a year for blood tests to make sure they're okay. Some people see their doctor less frequently than that, though, as most people with these early blood changes remain well for many years. The problem is that the current routine blood tests aren't very good at identifying in advance the people for whom these blood changes will get worse over time. And we need to learn more about how living with these blood changes impacts on quality of life and well-being. So better tests and the Oxford Precancerous Lymphoproliferative Disorders Study, or OxPLoreD for short, is committed to developing these. Doctors and scientists think that studying the changes in the DNA of blood cells and the immune system in detail, and combining it with other clinical features, will provide the answers. DNA is like an instruction manual for making each cell, including the proteins a cell needs to do its job, and studying changes in the DNA of the abnormal blood cells can provide clues as to how and when cancer starts, as well as how it progresses over time. The study is recruiting large numbers of people with precancerous blood changes like monoclonal B-cell lymphocytosis, also known as MBL, and monoclonal gammopathy, also known as MGUS. These people either have a small increase in the number of abnormal B lymphoid blood cells or an abnormal protein in their blood. The study will also recruit people living with early-stage lymphoid blood cancers, such as early-stage chronic lymphocytic leukemia, or CLL, who don't need treatment. People participate in the study by providing samples of blood and bone marrow cells. It won't take much of your time, but you could be contributing to one of the most important studies being undertaken that could have a huge impact in the future. Go to oxplored.oncology.ox.ac.uk to find out more about participating in OxPLoreD. Lines are open Monday to Friday from 10 a.m. until 4 p.m.
So there was one question through the chat box I saw about how people might contact us or find out more about the study. So here's on the slide you can see is our website, and myself and Caroline Haddon, who is the study nurse who's on this webinar somewhere, to contact us. Currently, in part largely because of COVID, we're only open in a limited number of sites. So at the moment I can't pull people down from Scotland to come and have their study assessment. We have, I think it's 17 sites around the UK at various stages of setup for this. So my hope is that by the time everyone's vaccinated and COVID has settled down, there will be a centre, within a short drive of most people. I had some questions in the pre-webinar submission about how different treatments work for CLL, and this is a fairly technical schematic. What I think the most helpful way to think about it is to think about locks and keys. If you think of the CLL cell as being kind of like a little mechanical thing with lots of different locks on the surface and different keys that you turn in different ways to either cause the cell to grow or cause the cell to divide or cause the cell to do some other thing. Each of these targeted treatments act on a specific lock, either by turning it in a different way or jamming it, so so the biological signal can't get through. And they work. Rituximab is probably one of the best known. It's attacking the or blocking the CD20 function. You've got this BCR receptor here, which is where and BTK, which is where the likes of acalabrutinib and ibrutinib work together. Campath, which is a very historical treatment for CLL at this point, but because ABT199, now known as venetoclax, because they work in targeting different parts of the CLL cell, it's often helpful to combine them. And so you see studies looking at venetoclax and obinutuzumab or venetoclax plus rituximab. I probably would, maybe it's time to move on to some questions.
Thank you very much, Dr. Appleby. That's an interesting talk, and we now, if I can, just move on to a few questions. First of all, just to recap on the work that you're doing, as I understand it, there's a whole section of newly diagnosed patients that may never need treatment. Yeah. So essentially, what you're trying to do is to identify those people, and then you can move on to the other 2/3 or whatever, and look at treatment for them. So you can identify the first 30% or whatever that actually will never need treatment or are unlikely to need treatment, and leave them alone and start to treat the other segment. Is that correct?
Exactly. I mean, how powerful would that be to be able to have a conversation with somebody to say, your marker or your selection of tests suggests that this is not going to progress up to 10 years. And what you need to do is concentrate on getting your vaccinations and your, the living well stuff.
Just go ahead with living.
The converse of that is, we'd have people with early CLL whose, tests and markers have shown up that this is somebody at risk or with a high probability of the disease getting worse over the space of a year or 2 years. And these are the people that we can monitor closely, or maybe even set up the next trial looking at some of our targeted treatments in that group.
And how close do you think that you're getting to that point? Or how far away are you?
Well, I mean, the idea of doing clinical studies on early CLL is not new, and there's ones happening around the world. I think they have, I suppose, failed in that they've not demonstrated a benefit to early treatment so far. But part of the reason they failed is they've not been asking the right question and not been treating the people that really need it. So I think step one is, let's find who really needs it, which would be that minority of patients that are going to progress over a shorter period. And that's the group that you bring forward into a clinical study. So I think, OxPLoreD as a study has been running for about 12 months now. So it's going to continue to run for sort of, let's say, we want to follow these patients on study for 5 years. And let's say it'll be another year on that for readout. This is a decade's worth of work.
Okay, so we're say 10 years away from having a solution to this problem.
Well, I think step one, I mean, the first part of it, or having an answer to the question, is who is most likely to progress, and can I, use some is probably less than 10 years. Having a trial run on the back of that test would be, I think, the guts of a decade.
Okay, fine. Do you think this is going to lead towards more personal treatment? Are we able to say that we're already able to say that TP53 deletions and 17p and so on are a subsection, and certainly FCR will not tend to work on that section of people, whereas the newer lines of treatments probably will. Are we getting closer to more identification of a particular person and tailoring to that particular person a type of treatment?
Yeah, I mean, somebody in the chat mentioned the immunoglobulin mutation status, and that, for anyone who doesn't know, is sort of an immunoglobulin heavy chain is a gene that's important in B cells. In CLL patients, you can broadly divide them into two groups: people in whom the gene is unmutated and people in whom the gene is mutated. Somewhat counterintuitively, it's the group in whom the gene is mutated where the disease tends to behave a little bit more indolently, and the group in which the gene is unmutated tend to progress a little bit more rapidly. That is a very useful tool when you're talking about big groups of CLL patients. So when you have, 300 patients on a clinical trial and you want to try and describe them. If I have one patient in front of me, it is less useful, because on on an individual basis, it's only something like 60 to 70% accurate. So, and I think if I'm going to bring somebody forward to a treatment on that basis, I need a better number. That number needs to be more robust.
Sure.
So, I mean, if you'd asked me this question 3 years ago, 2 years ago even, I would have been predicting that we would be saying something like the targeted treatments will be for people with unmutated, and the FCRs and that kind of thing will be for people with mutated. I think the data that's come through over the last 18 months shows that the targeted type treatments work really well for the mutated and the unmutated. So, it's not panning out as I had predicted. And that's we've only talked about two parts of the genome so far, the P53 and the IGHV. And there's, you've 30,000 functional genes in a human genome.
Yeah, I guess one of the most exciting things is how rapidly it's changing. I mean, go back 10 years and we were almost certainly going to treat people with SCR. Now there are a whole range of treatments. And the last slide that you showed, which was quite complex, showed a cell and all the different pathways within that. And if we look at, let's say, ibrutinib and venetoclax, which are BTK and BCL2 inhibitors, there are many, many other pathways. Are these pathways being explored, and do you know whether there are therapies, treatments being explored as well?
Yes. So one of the, I suppose, there's a pathway called SYT, which interacts and talks to the BTK pathway. And that's been, there are current clinical studies going on about that one. One I'm particularly interested in is basically a DNA damage repair pathway, which work done in our group has shown that's been particularly important in how Richter's syndrome develops and responds to treatment. So Richter's syndrome is this high-grade transformation of chronic lymphocytic leukemia where it starts to behave more like an aggressive lymphoma and then is treated more like an aggressive lymphoma. And that may, I don't want to get too technical, but your audience might be familiar with testing for 11q deletion.
Yep.
And a gene called ATM sits on 11q, and that basically the DNA repair mechanism treatments might be particularly important for CLL with 11q deletion.
Yeah, and we're now getting many more combinations. I mean, VNO, venetoclax, and oportumumab, the recent combination that's been approved by NICE. FCR started with one, then another chemo came in, and then another treatment. Yeah. Do you see the same thing? In other words, perhaps in 2-3 years' time, we'll have 2 or 3 combinations of these treatments.
Yeah. So I guess anticipating what things are to anticipate in CLL treatment. What the first targeted treatments that came through, and the ibrutinib and single agent venetoclax, were essentially designed to be taken indefinitely, designed to be taken as long as they were working for someone. So you took it and you kept taking it until either you developed a side effect that meant you had to stop it, or the CLL started to grow again. And I think the question about combining these treatments is going to be a little bit around, can we do a little bit better? As in, can we use a combination of targeting the CLL drug in 2 different parts of the CLL to get a very deep remission? And I mean, I haven't mentioned minimal residual disease testing, but maybe that's another question.
Yeah, that is another question. I'm coming to that one.
That we get a very deep remission, so where we can't detect any CLL, and then we stop tablets. And can people safely stop tablets and stop treatment at that point? I think that's the big question coming down the line is, does everybody need to be on these targeted treatments indefinitely? Or if we do a combination of targeted treatment to get to minimal residual disease negative, can we then stop that? And I know Peter Hillman coming next month, and he will probably mention this a lot. It's been one of the questions. The Clarity trial has been very interesting.
Yeah. Yes. Yeah. Am I right in saying that VNO is actually for a limited period, for a year?
You're right. Yes. Yeah. So there's 2 options that have come through NICE with venetoclax. 3 if you count single agent venetoclax. Venetoclax and rituximab has been approved for relapsed CLL. Venetoclax and obinutuzumab, they're all tongue twister names, has been approved for high risk frontline CLL. And both the ibrutinibs plus venetoclax plus the infusion of the anti-CD20, either rituximab or obinutuzumab, is approved in a time-limited fashion. So I think one of the questions that had come through was around why somebody who was wondering why she was being offered one venetoclax option versus another. It may have been her clinician's thoughts around the time-limited duration of a venetoclax plus CD20 versus the benefits of long-term venetoclax, and that is a very rapidly evolving area.
Yeah, sure. You touched upon MRD, minimum residual disease, briefly. some people gain MRD fairly quickly, others much more slowly, and some never do. What's the sort of explanation behind that? What's the thinking behind that?
Yeah, I mean, so at the moment, when we talk about minimal residual disease testing, we're usually mean testing the peripheral blood, testing large numbers of white cells in the peripheral bloods, and looking for any white cells that express the phenotype or express the I suppose, size, shape, and color for, of a CLL cell. Sometimes we're also we pair that blood test with a bone marrow test, also looking for the size, shape, and color of CLL cells. I mean, what we're not doing is looking at minimal, if there's any leftover CLL cells in lymph nodes. So some of the this, there's a bit, I mean, most people who get, we don't have a good tool for looking in lymph nodes. So when we're able to look at minimal residual disease, we're not able to see the full disease well, I can say, and we could, I mean, does that matter? Because it's certainly, if we get to minimal residual disease negative and then stop treatment, what we want to know is how rapidly the CLL will regrow. Because if it resets the clock back 10 years and you now go from, and your minimal residual disease level is very small and it regrows very slowly, then for that person, they probably don't need to eradicate every last CLL cell to live a good quality of life. Whereas if the converse is true and you have minimal residual disease, but a disease that rapidly regrows, that person probably does need to aim for eradication.
Yeah, so sorry, we're talking here basically about managing the disease.
Yeah.
Do you see a time when we will be able to cure CLL, or is it going to be ongoing? We just manage the disease and get people to be able to enjoy basically life as best they can. Is there such a thing as cure for CLL?
Yeah. I mean, I guess what is more important to people? I mean, the average person with CLL, starts their pathway in their early 70s, and I'm thinking. I'm conscious of balancing any toxicity of treatment, because we wouldn't be doing anyone any favors if we gave them a pristine bone marrow, but they weren't able to get out of bed in the morning.
Of course.
So,
yeah. I'm thinking particularly about younger people, because we have an under 60s group and it's growing, and younger people do seem to be coming forward a lot more, and they have a much greater life expectancy. It would be great if they didn't have to take treatment forever, but for a shorter period of time, and or obtain a cure. Now, I think the only times that a cure has been stated is with FCR, and some people do appear to have a cure from FCR, even though it's a very aggressive treatment, and also stem cell therapy, which again is extremely aggressive. So are we ever going to be able to take a pill which will offer a cure, or is that fantasy land?
No, I don't think it is fantasy land. I think
that's good.
But we have seen some people with relapsed chronic lymphocytic leukemia get to a state of minimal residual disease negative bone marrow, so there's no CLL by the testing that they do in their bone marrow. Now, that is a minority of people, and minority of that group have stopped their treatment, usually because they run into side effects, and have stayed minimal, have continued to have normal blood and bone marrow results after a couple of months off treatment. So that's very encouraging. But I think we've a long way to go between that cohort and saying it's generally applicable. I mean, this, I'm sure many people in this audience have heard of the FLAIR trial and are participating in the FLAIR trial. One of the arms of the FLAIR trial is exactly that, combining ibrutinib and venetoclax for younger people requiring their first line of CLL treatment. And they will have minimal residual disease testing as part of that. Yeah, I mean, I think CLL treatment, or CLL, I mean, I find it particularly interesting because it needs a lot more individualization than many other diseases and many other treatments, both because the patients range in age, but also because the disease ranges in behavior.
Yes, almost every individual is an individual as far as CLL is concerned. It's a very heterogeneous disease, isn't it? This is another technical question, and then we'll move on to a few more general ones. Venetoclax and oportunumab combine a BCL2 inhibitor with a monoclonal antibody. Could you explain briefly for a layperson like me what the difference is between the two?
Okay, so venetoclax is given as a tablet, whereas the monoclonal antibody is typically given as it's given as an infusion, you know, 9 times out of 10. And so that, you know, how they look and feel going into you will be different. The obinutuzumab, you know, goes in as a drip. It's usually given in the day ward. And some people, as the infusion goes in, get shivers and shakes, and as it's monitored. Usually, venetoclax, depending on the stage of your CLL and the sort of your general status of health, may also be offered as an inpatient for the start at the start. The reason we do that is it's quite an effective drug at, you know, destroying CLL cells, which obviously is what we want. But when you get a lot of dead and dying cells happening at the same time, they release all the gunk, particularly potassium salts and other salts, from the cells into the bloodstream. And that gives your kidneys an awful lot to do in a short space of time. So for someone starting for everyone starting venetoclax, we start on a low dose and increment gradually over 4 weeks with monitoring of your blood tests, so your blood salts and how well your kidneys are doing. And for, you know, there's a group of people that were, I guess, this syndrome where the CLL cells die off and release potassium and your kidneys struggle. It's called tumor lysis syndrome. And there's a group of people within CLL that are, I suppose, identified as being high risk of having tumor lysis syndrome. So that may be because they have a lot of disease on board when they come to treatment, or because they have a pre-existing kidney condition that needs extra monitoring. So in that group of people, we saw, you know, these are the venetoclax is started in combination with things like IV fluids, either requiring sort of daily visits to a day ward, or someone being kept in overnight at the start of the infusion.
Okay, thank you. Now, some of these questions I'm not sure whether we can answer, but these have come up today. They're regarding the vaccination.
Yes.
Vaccinations that are going on at the moment. Several people are concerned about the delay of 12 weeks between the first and the second vaccination. Should they be concerned about that?
I mean, I guess I guess as we know, the UK have made it a sort of national policy that people will get their first dose and then their second dose 12 weeks later. And that is own controversy, because that is different to what happened in the clinical studies, and it's different from many other parts of the world are doing. Based on how vaccines work in general, I don't think it's going, you know, that gap of 12 weeks is not going to ultimately make the vaccine less effective. In that, you know, it's just going to take longer to get there. And that's a concern, you know, because of the, you know, that's it's, you know, you're living with the protection of one vaccine rather than the protection of two vaccines for longer. And the sort of national body with responsibility for vaccinations did adjust its guidance a little bit just earlier this week for people who are about to start treatment that can affect their immune system. So they have said that people who are about to start treatment that can affect their immune system should get the vaccine 2 doses 3 weeks apart, ideally before they start this. So in practice, that means if somebody knows they're due to start treatment end of February, 1st of March, they need to be we're still working out the logistics, because a lot of our patients would have had their first dose with the GP, and do we bring them back to the hospital for the second dose? But that, and I'm sure every other centre is having similar questions. But there is I think that a sensible decision there for people coming into treatment to get their vaccinations before they get treatment.
Thank you for that. But we've also had somebody who's concerned about having a different type of second vaccine. I don't think that's actually going to happen.
No, that's not my understanding either, barring sort of catastrophic supply issues. That the sort of national program is, if you start on the Oxford AstraZeneca one, you will get 2 doses of that, and if you start on the Pfizer one, you will get 2 doses of that, and presumably the same for the next ones that get licensed and come through.
Yeah, someone else said, I've just recovered from shingles. Should I have a vaccination?
Well, you shouldn't have the shingles vaccination, I think.
No, should they have the COVID vaccination?
So the only limitations on the COVID vaccination are if you've had a positive COVID test or symptomatic COVID, they ask you to wait 28 days before coming for your first vaccination. If you have had a history of anaphylaxis, particularly anaphylaxis to vaccines, that's something you need to discuss with your vaccination centre. And that might be somebody, if you're somebody that has a history of anaphylaxis and carries an EpiPen, you might be somebody who needs to have your vaccine done in the hospital rather than with your GP practice or out at a drive-in centre. There's very few absolute reasons somebody should not get a vaccine.
Okay, thank you. This is a question about vitamin D.
Yes.
There's been quite a lot. In fact, the government has now issued to certain people free vitamin D doses. There's a question about should I take vitamin D? Will it do any harm? And also the amount. I've seen on our on our forum, Health Unlock, people taking enormous doses of vitamin D on the basis that if a little is good for me, a lot must be better. And I know, I believe that vitamin D can be toxic in large doses. What's your recommendation on that, Dr. Appleby?
So, I mean, long before COVID, I've been telling my CLL patients to take a vitamin D supplement. And that's on the basis of some fairly weak science, which suggested that people who were deficient in vitamin D, so had levels less than 30, their CLL got worse a little bit quicker than people who had good, healthy levels of vitamin D. And we know vitamin D has a role in the immune system. It's not always clear what exactly it's doing at each point. But on the basis that it was going to be good for your bones, it was going to be good for your immune system, it may or may not be good for your CLL, but I thought it was worthwhile. I've been saying that to my patients for a long time. Lost my track there. In terms of dosages, so we sort of say over 30 or ideally over 50 is kind of normal vitamin D. In order to sort of get the benefit of the immune system effects of vitamin D, you need to be well over the lower limit of normal, so sort of 75 plus of a vitamin D reading. In terms of the dose, there's a huge variability in what dose you take, depending on what your level is at the start and where you're trying to get to. Because I know in our own practice we use a sort of a replacement course, which is 400,000 units of vitamin D once a week for 7 weeks, and then they drop back to a more a more standard over-the-counter vitamin D dose. So it's quite difficult to overdose on vitamin D. It can cause, you would have to take quite a high dose for quite a long time, and the sort of problems it can cause with high dose of vitamin D is around kidney function and kidney stones. Does that help clarify or cause more confusion?
But basically, you'd recommend people to take relatively small doses of vitamin D. Can't do any harm, and it may do some good.
Somebody has quite rightly commented in the chat, if vitamin D is also known as the sunshine vitamin. But of course, if you're protecting your skin from ultraviolet related damage, or you're living in self-isolation mostly indoors, you're not getting any sunshine.
Sure.
You're not getting any sunshine vitamin.
Exactly so. We've got time for another couple of questions, I think. Back on the vaccination question now. Do you know of any side effects to any of the vaccines for CLL patients at all? I haven't heard about any, but...
no. I mean, we know that both vaccines were so the vaccines so far have been tested in something like 40,000 odd people in the trial, and then however many thousands have been vaccinated in the UK and worldwide since. So CLL patients certainly have been vaccinated and probably were part of the trial, whether they knew it or not. The trials did allow people with a history of leukemia or lymphoma to participate, so there were probably some people in remission on that. In terms of the data we have so far, there isn't a different side effect profile for people living with CLL than people who've never had CLL. So I think we can expect the same sort of issues, about 1 in 3 people having a sore, achy arm, occasional people having a low-grade fever, and those sort of reactions being relatively common.
Thank you. There was a very interesting piece on the forum recently from an American doctor who said he had a most peculiar experience when he had his vaccination. He sat there for 15 minutes and he couldn't work out what it was, and suddenly he realized it was happiness.
Relief.
Exactly. Exactly. Is there any information yet on which of the 2 vaccines that are currently available is preferable for CLL patients?
Either of the vaccines are suitable for people with CLL, and I should just specifically mention there has been some confusion about the Oxford AstraZeneca vaccine, because this has been made using a chimpanzee virus as a starting point. The chimpanzee virus has been modified and deactivated, so it's not able to grow and replicate. So the Oxford virus is not considered a live vaccine, and therefore it's safe for CLL patients.
And the Pfizer one, of course, is an RNA vaccine, and
there's nothing live in that either.
Yeah. So they're both entirely safe. Yeah, this one says, I booked in to have the vaccine soon, no idea which one. Would like advice on whether people with CLL should wait for a second vaccination until we can feel safer going to the optician, to the dentist, physiotherapist, and most importantly, of course, hairdresser.
Yes.
So should they wait basically until the second vaccination?
Yeah, I mean the guidelines for people after their first vaccination and after their second vaccination is to continue with your hands, face, space, hand washing, mask wearing, all of the distancing measures that you're doing at the moment to protect yourself. Because I guess this COVID is not over. There is concerns about new variants of the virus coming in or developing in the UK. So far, the vaccine is effective against these new variants, but we don't know whether that will be an ongoing question. While I can be pretty confident that the vaccine is safe for people living with CLL, I am not, or there is a question about whether people with CLL will derive the same protective benefit from the standard 2 dose. I mean, that's something we're looking to study further in Oxford, but also so it may come out kind of at the end of the year, 12 months down the line, that actually people with CLL need 3 doses, or a different dose of the vaccine to achieve the same level of protection. So I would love to say, go and hug your grandchildren and go and book your haircut, but I don't have the data to do that at the moment.
Okay, thank you very much. Well, thank you, Dr. Appleby. I think we've come to the end of our time almost now. It was a fascinating discussion. Thank you very much. Appreciate it very much.
Got something out of it.
Well, we know you're extremely busy, so thank you for devoting your time to us today.
No, thank you for having me.
You're very welcome.